right, we're going to get started. Sorry, that was a little bit of an abbreviated break, but thank you for being here and look forward to moving forward. A couple of announcements again. Silver Toyota Tacoma, 4 parking spots. Let's decrease that down to 1 if that's one of us. We also, our keynote tomorrow is Dr. Jeffrey Anderson, who actually was the cardiologist for Barney Clark, who received the first artificial heart. He recently received the Spencer Fox Eccles Distinguished Service Award, and we look forward to hearing from him, but I wanted to make that announcement. Our next speaker is Dr. Greg Osmond. He's probably my most favorite Osmond of all of them, so I'm grateful to have him here. He's a board-certified physician, a pathologist, and an experienced healthcare executive with a proven track record of leading transformative, high-impact initiatives in healthcare, especially in laboratory and health tech sectors. Greg's company has been my pathologist for the last 4 or 5 years, probably, and very innovative stuff that he's done. I can pull up pathology on my phone and show my patient, hey, this is what your cancer looks like, this is what the margins look like, and actually able to walk through with my patient, why I'm deciding to treat their cancer the way it is, which is pretty cool. Before I started using his service, it was taking a week or 2 to get the results back. I usually get the results back in 24, 48 hours, which is really cool. But also he's kind of harnessed the power of artificial intelligence to speed up that workflow. If I want to bring AI into my clinic and want to get things moving forward, or want to get a committee of people to say, hey, how can we have AI help us be successful in medicine, Greg is the first person that I call for that. So I look forward to hear his insight in using artificial intelligence in his own specific, kind of part of medicine. But I think there's some lessons that each of us can learn in terms of how we can do this. And like we said yesterday, I think those of us that can use artificial intelligence in our practice, we'll be better at what we do. We can take what we know and actually make things run smoother and better and take better care of our patients. I think those of us that do not, I think will be left behind, which is the unfortunate reality. So look forward to hearing from Dr. Osmond, and this is going to be great. So thanks, Greg.
All right. Well, it's my privilege to be here. I'm not from Ogden, but I claim Ogden. My family's from Ogden. My dad just got buried here in Ogden, just down the street, not too far. My mom's family's from Ogden. And I work with a lot of physicians in Ogden, in the area up here. But I am a pathologist, so I know that means that I'm weird. And I fully embrace it. I am not a normal physician, just in terms of what interests me and how I like to sit in the basement by myself and not talk to people. I enjoy that. So, but out of curiosity, are there any pathologists in the room? Is there a single? Oh, nice. Okay, well, we need to connect. If we haven't already, yeah, okay, great. Is there any other pathologists in the room? Okay, cool. So I expected that. I'm not going to talk about pathology. I don't think anybody cares what the slides look like and how to diagnose, the various diseases. But I am, so what I decided would be interesting, so I have no idea how much exposure people have to AI, and AI means a million different things depending on what sector you're in and where your interests lie. And so what I'm going to attempt to do, I guess my overall objective is actually to get you guys, or to get all of us rather, to self-reflect on your practice. Okay, so every physician specializes in some area where you feel like you really understand it. Even if you're in the same specialty as who's sitting next to you, there's an area inside of that you have really mastered. Better than anybody else in the room. I would imagine there's something in healthcare that you've mastered better than anyone else in the room. And when it comes to rolling out next generation systems, which are being rolled out now and developed now, there is a competitive advantage that you have, an insight that you have in order to roll out this next generation system in that area that other people don't understand. And that was true for me in dermatopathology. That's the reason this company that I'll talk about, I actually have sold it as part of my disclosures, so I don't have ownership in that company anymore. But It is the only reason that it worked is because I knew every little detail of my specialty, and there are other people in the market, people that started 10 years before me that had $100 million more than us, and we beat them in the market because I understand the nuance of my specific specialty, and they didn't. Like, that's really the details. I can make something operational and make it make financial sense. I understand the reimbursement and how it's going to work. And a lot of the tech companies that build, they're like, hey, they're building research projects. They're like, hey, this technology is amazing. Guess what? When you plug it into a real clinical workflow, it doesn't speed you up, and it actually slows you down. And yeah, it may be cool, but it's not actually helpful in a real practical way. And physicians and providers stand in a unique place where you can really make the assessment very easily. Like, you could spend an hour assessing a product and say, yeah, I would never use this, and it would need these 5 things in order for me to use it. Most of the tech companies don't understand that right now. And so it really is it's a unique time. It's a unique time to practice healthcare with all of these products coming online. And that may be of interest in some of you. Maybe the rest of you, like, don't care. You're like, I'll be retired in 5 years. Like, I don't even want to be involved. And that's fine too. But it's just good to know about. And so we'll end up, so in the context of this, I'm not going to try and educate you on what I did or like all the details. I just want you to open your perspective a little bit and think, what could be? Like, what could be in my practice or in my healthcare system that I work in? What really could we develop? And the truth is that we are so new and early in this space that any group that is committed to do it, any healthcare group that's committed to do it, can win on a global level right now. That's how early we are. We're so early. And we'll get into that a little bit. Pathology Watch Inc. is a company that I started, and I've since sold, but it's been within the last 2 years, which is part of the disclosure. It's been years since I did some advisory work for Castle, but so anyway, it's on there. So those are the objectives. This is my family. If you know the Osmond family, this is them, according to AI-generated images. So I think that guy in the dark hair is probably Donnie. Merrill's with the beard next to him. My dad's probably the one on the left. It kind of looks like Wayne. Like, these are totally fake people. It looks fantastic. I just added in. It took me half a second to generate this. I said, I didn't give it any images. I said, make the family of Greg Osmond, and make it in a way so that everyone knows that they're in Ogden, Utah. And this is what popped out. So this is a little gimmicky, but I just don't know what people have seen. This was free, and it could be automated. So that's just an example. It's another product. I just gave it a prompt, and this is really high quality. You look at this image on the left, that headshot, that physician, that, if you went through a conventional method, that'd probably cost you $2,000, $3,000 to do. Like, hire the model, hire the photographer, get the whole thing done. That was free, and it took about 3 seconds. Same thing with like the cartoon image. That would cost at least a couple $100 if you did it through some freelancer site. And these are applications that people do these with deep fake videos. You see them on social media if you're on with your whoever. And yeah, it's gimmicky. Like, how does that apply to healthcare? It applies to healthcare in a huge way. And the reality is that most people don't see how it applies to healthcare, but the physicians can see it. Like, if you really sit back and think about my practice, what's going on, how do I make care better and cheaper and remove the manual tasks? Can I really cut my staff from 10 down to 5? Like, what needs to be automated? And the truth is, you absolutely can. So I'll get into, my whole company was built based on like very simple Google image algorithms that we reapplied into healthcare. And so that's what these are. It's like very simple generative algorithms. And you have to take control, and you have to be careful, and you have to have a really good data set in healthcare and reapply it. So it takes time and work. But if you understand what's kind of in the broader market, so I just modified the prompt a little bit to try and create Adam Tainter, and I think I nailed it on one of them. So the guy in the black suit, I mean, that kind of looks like Adam right there, don't you think? I mean, I didn't even give it Adam's face to compare it. This is what, so I was able to like, so it's pretty cool what can happen now. And we are in the extremely early days. So a lot of companies are built on a backbone of Google or Microsoft or something similar. So they're coming up with their own workflows and products. So my company, we use Google. And when I was coming up with a presentation, Google actually prompted me to create my videos using Google Vids, which I didn't even know that was a thing. And it's already automated in with my Google Drive, and it can pull any of my documents, and I can say, make me a video of this. And it did an okay job. We're not going to watch it. Let's see here. Because I did another one with ChatGPT in a company called Synthesia. And so this was the prompt. This is all I did. I typed this in to ChatGPT, make a PowerPoint presentation with 4 slides covering key points that a dermatopathologist should teach to a general practitioner, like a family medicine, PA, or a general surgeon. Okay, so I typed that into ChatGPT, and then I took the output, dropped that into Synthesia, which is an AI generated like educational video platform that I use, and then I had to wait 20 minutes, and this is what came out, and this is what we're gonna watch. I've watched it. You can tell me how accurate you think it is. I feel like it nails it exactly what I would want to say in an actual presentation. Make it super concise. I made one edit is all, and it kind of messed up the English. So you can probably tell where my edit was because it does make some grammatical error, but that's because I modified it. So hopefully we have audio. Do we not have any audio?
Which can save lives. Remember the ABCDs of melanoma: asymmetry, border irregularity, color variation, diameter over 6 mm, and evolving lesions, and everything else. When evaluating a patient and determining whether a biopsy is appropriate, consider the patient history, including immunosuppression and prior skin cancers. When in doubt, opt for a biopsy or a referral to dermatology. Early detection is key to effective treatment and better patient outcomes. Different scenarios call for different biopsy techniques. Punch biopsies are ideal for inflammatory rashes or suspected infiltrative malignancies. They provide a deep tissue sample for accurate diagnosis. If the inflammatory process is deep or the tumor deeply invasive, you need to biopsy the deep dermis or even subcutaneous tissue. Shave biopsies are perfect for raised, superficial, and isolated lesions. They are commonly used to diagnose non-melanoma skin cancers so that they can be definitively treated thereafter. Excisional biopsies are best for pigmented lesions or when melanoma is suspected. Always aim to remove the entire lesion if melanoma or an atypical pigmented lesion is suspected. When filling out pathology requisitions, include clinical differentials, lesion details, and patient history. Including clinical descriptions and photos can significantly enhance diagnostic accuracy. Above all, tell us what you think the biopsy represents. It doesn't matter if you're right, and it greatly helps the pathologist return back to you a report that is helpful and accurate. Flag new or recurrent lesions for precise pathology results. More information leads to more accurate diagnoses, ensuring better patient care and outcomes. Identify when to refer patients. If a pathology result is unusual, atypical, has an unclear diagnosis, if the process is persistent, or if you aren't sure what to do next, consider referring the patient to a specialist. Timely referrals can significantly impact patient outcomes, ensuring they receive the care that they need. When making a referral, ensure comprehensive information is provided to specialists for better patient care. By doing so, you'll facilitate accurate diagnoses and effective treatment plans, ultimately improving patient health and satisfaction. Remember, the greatest single thing to remember is to tell the pathologist what clinical process you think that you are sampling. This will greatly help the pathologist to provide you answers that are clear, concise, and helpful.
All right, so does she look real? I mean, it looks so good. And we're in the early days. Like, this is alpha version. Okay, so like the technology is incredible. The content, I mean, anybody feel like there's anything inaccurate? I mean, I'm not a. I mean, the content was great. Frankly, I would rather listen to this than a 10-minute lecture by a human on the topic. It was like very concise. The background video is engaging and appropriate. The histology image was not a skin image, and we guess we have one other pathologist in the room, so like that was probably the wrong image to show, but it was a histology image, and it did extremely well. Okay, so how does this? So this obviously there's like educational value in this, but we'll have some time to talk through some scenarios as to how things could apply to healthcare even better in your practice or in the future, your specialty. But let's say somebody emails you, a patient emails you, and they've got a question and they're upset, okay? And let's say you're an oncologist. There's 5 different oncology groups in town, and the patient, if the same patient emails the same question to 5 oncologists, and one oncologist responds back with a video where the AI avatar is the oncologist herself, and she gives a concise video describing exactly all of the issues for the patient's problems, tell them exactly what to do, where to go, what you need to do, and that's what your 75-year-old mother gets versus some conventional email. Like, which one is going to be more impactful? Well, in terms of who is your mom going to want to go see, and which one is going to do a better job at educating her about really what needs to happen. Or about say this is a video on medication management, and the AI, avatar is the nurse practitioner that oversees that in your practice or whatever, and so this is what they get, and it's personalized to her or him, like to the patient, and this is the type of interaction that they're getting. And furthermore, let's say that this is a video call. And rather than it being a one-way video, they can talk back and have a conversation with the avatar. This is real. Okay, so I know that that piece is not in healthcare, but it's 100% possible right now to do that. Like, this is not technology that we need to wait to develop. This is already here. It's just a matter of how does it get applied? How are we going to apply it in healthcare? And what I worry about is how are other people going to apply it to healthcare and force it on me down the road. That's actually the real reason I started my last company, is because I was worried somebody else was going to do it, and then I'd fall under consolidation and be working for some other person who does this. And since I know that I've sold that company, but there's probably 5 more. So since I started it, there's probably 5 more that have started up doing almost exactly the same thing. And so I was really glad that we did it first. And so So anyway, I don't have any answers of what you should or shouldn't be doing. I'm just trying to provoke you to think, take a step back and think at your healthcare system. How do we apply this? How could this be applied? How could it make health? And we talked a lot about value-based care yesterday. I know Governor Leavitt was here and talked a little bit about, well, how does technology actually decrease costs? Technology will decrease costs when it's applied appropriately. Most of the people building technology don't know how to apply it appropriately. The absolutely do, and so do the providers. So if you were personally gonna drop $1 million into building an algorithm, you're gonna make sure that algorithm actually does what you need to save you money down the road. Most of the people in the tech space, they're like, oh, it'll be used for something, let's just build it. And so there's a huge competitive advantage for physicians that really want to get involved in this. And build the future inside of your healthcare systems. All right. Okay, so the key points, the key point of the lecture, my key point, the only thing that I really have to say as a pathologist is, will you please tell us what you think that you're biopsying? Like, that's it. Everything else is really good. Like, if you want to give us a lot of information, that's great. But at a minimum, just say, I think this is X, and that helps so much. And I'll give one example. So let's say it's a basal cell carcinoma, and you're like, oh, I'm going to just say it's a lesion and send it in. When I see a lesion, if it comes in with clinical history of lesion, what I think is it's probably automated out of their EHR, and this is not actually representative of the clinical history. That's what I think. Or if it comes as some stock statement from the EHR, you can tell that their EHR generated this clinical history. I question whether it's real. And the ones that are the most helpful is when it comes and it just says basal cell. That puts it all into context for me. It's an isolated lesion. They think it's a basal cell, and my report back is going to be super helpful. And if it is a basal cell, my report back is going to say it's a basal cell. But when it's not a basal cell carcinoma, and so let's say it's a lichenoid keratosis, which I'm sure if you do a skin biopsy, you've had that come back before, as it could be a lichenoid keratosis. If I get a clinical history of lesion or something nondescript, and it has the reaction pattern of a lichenoid keratosis, I'm going to give you back a really ugly report. It's going to come. My diagnostic line is going to be lichenoid interface inflammation C note, and then I write you a big note. And if you would have just said, oh, I think it's an SK, and then my report back is going to come back as lichenoid keratosis. It simplifies it for you. Just because in derm path specifically, and also other areas of pathology, the reaction patterns can look identical, and there's no way to differentiate it other than knowing what's going on with the clinical history of the patient. And so you guys can't always foresee when that scenario is going to happen, but they do happen. And if we just don't know what's going on, we end up giving you back this unhelpful, vague answer where it could be 15 different things. And so nobody wants that, especially the patients don't want that since they get the reports most of the time. And so that's really my take-home point of the whole thing. So take-home point number one is just tell us what you think that it is. If you say what you think that it is, you'll get a way better report back from pathology. And then the second one is that just to demonstrate how impressive the generative AI features are right now. And we're in the very early days of where they are and how they're going to be applied. These are, for a show of hands, does anybody use any AI products today in your clinical practice? Okay, so those that do, so there's not very many. Are we talking, does anybody have a microphone sitting in your patient encounter and automating your note? So we do have a couple. Okay, so that one actually is decent number of people that have that. And does anybody dislike that? Anybody having a bad experience, like, oh, this is worse than the way it used to be? Okay, so it's an improvement. So for people that aren't using it, it is a major improvement. And then what about automated emails? Does anybody have, instead of having to answer your emails, they're already answered and you just have to go approve them? Is anybody using that technology? So maybe one person. They're amazing. And patient responses are that when the doctors who use them, and the patient kind of does a survey after, is that, oh, the doctor's so much more compassionate. He or she understands me so much better, just because the amount of psychology that these, if you go into ChatGPT and psychoanalyze yourself, you'll get an amazing response back as to the human psyche. It's amazing. So if you're not familiar with it, you should check it out. But the products are better than human. So they're objectively, patients like the AI-generated emails better than the doctor-generated emails. It's just objectively they prefer that. And so that may be something for you to look into. There's some early day products that do that, and a couple of them are listed there. Does anybody get a text message when a patient shows up at the ER and says, hey, this might be a stroke? A radiologist hasn't even looked at it yet, and you get a text message that says, hey, it might be a stroke. Okay, so your systems aren't using that. Oh, okay, so somebody is getting that. So that is actually the first product that kind of broke the FDA and opened the FDA up for algorithmic use cases in healthcare. So it was called Viz.ai. When that got approved by the FDA, that's when I started my company as soon as I found out about it. Because I was like, okay, the FDA is green lighting that these are going to be able to be used. So there's a bunch of other use cases. Pathology is one of them. I typed in how I felt about starting my last company, and this is the image that was generated. And I think it's pretty accurate about how I felt. And it is frustrating to work in tech and try and make products work in healthcare. It's super frustrating. I worked probably 90 plus hours a week for 5 years, to be totally honest, and I'm not exaggerating. And I was extremely well funded. I had a brilliant co-founding partner who is, we both trained at Harvard together, not at the same time, but he's a business software engineer, and we worked really well together, and he worked harder than me. So he's the first person I'd ever worked with that outworked me, that I couldn't keep up with him. And we did that for about 5-6 years, and we were highly successful. The company was highly successful. And that is, I don't know that you have to be that kind of crazy about it, and we were kind of crazy about it because we want to make sure we won in the space, and what we did, but there's a price to pay in this world if you want to be entrepreneurial and build things, because as soon as somebody else thinks that you have a trinket that might work out, guess what everybody wants? Is they want to take that from you, and they want to build something bigger and better, and it turns into, there's a lot of human psyche behind it. And so in the entrepreneurial game's not for everybody. Most physicians don't have the personality for it. But if you do, and if this is of interest, you don't have to go crazy the way that I did. If that is you absolutely should. Like, there is not a better time in the world to start a company if this is the type of space that you're interested in. And then but there are a host of people in this space developing, like software engineers and like data science people who don't have the insight to know really what they should be building. They know that there's an opportunity in this space, and say it's like dermatology or family medicine or whatever. They have to have a physician on board to guide them, or they're not going to know. The company's not going to work out well. So even if you're peripherally interested, it actually is a really good opportunity if it's something that you want to do. I just wanted to highlight here a key piece of what really happened about 8 years ago, or maybe 10 years ago. So do you guys get, people use like Google Photos or some other kind of photo program, and you can get on there and just type in, pull up pictures of skiing. And then it'll pull up all your skiing pictures. But you guys familiar with that? You've seen that? Okay. So 10 years ago, that was impossible. Nobody thought that was possible. And unless somebody had gone through the images and indexed them and said, oh, this is a skiing picture, like, you couldn't really query and find the pictures. And what happened was Google Mind released some algorithms that were highly sophisticated, like more than anybody could appreciate, where using the image itself with no indexing, they could find like a dog or find a cat and say, yeah, here's a cat, here's a dog, and pull it out. And so what it really is, and that's basically what we did in our company. We said, this is basal cell carcinoma, this is squamous cell carcinoma, this is an adnexal tumor, and we just had a series of algorithms saying yes, no, and we were able to basically automate my job. There's some, and we might not get to it, but in the presentation I have one of the public papers that we put out where the algorithms are amazing. They do a really good job. The pathologist will always need a pathologist being steward over pathology, but pathologists leveraging the technology, they could probably do 5 times the work in a day safely, and probably safer than it is right now. So it's a really good use case. There's a use case in your specialty too, I can promise you. And if you can't see it and you want to talk about it, I'm happy to talk about it and brainstorm whatever your interests are. But what really changed was, so when you think about conventional analytics, the research projects that you did in med school or whatever, all the data went into an Excel spreadsheet, and it all fit into a cell. And you're like, okay, it's a number or a feature, and that's all called structured data. It can be easily structured, which means dropped into an Excel spreadsheet in one of the cells. And so what is not structured is like a picture like this. How are you going to structure in an Excel spreadsheet all of the different features inside of this histology image? And furthermore, an algorithm is looking at ones and zeros, not the actual picture. And so how do you translate that into a computer? And so what happened with deep learning it took unstructured data, and in a highly sophisticated way, which we're not going to get into, it structures it. It structures it. So, and the way to think about it is it can take a video, so you can take a video feed, an audio feed, your whatever procedure you're doing, or like a radiology image or a pathology image, and you can now use deep learning to structure that unstructured data and make it structured. I mean, it's basically structured now in a very sophisticated way. And so then you can run deep analytics on it. And that's what really changed about 10 years ago. It's super novel, and it's game-changing in terms of now we can automate tasks that required a human. So it required a human to deal with all this data. And now all of a sudden you don't need the human. Like that's basically what's changed. So how does this get applied? How does this get applied in your specialty over the next 20 years or over the next 5 years? I mean, so in my opinion, you can either wait and see what other people do and impose on you, or you can, if you're interested in it, you can go create a small team of people who have the resources and the data, and you can build the future yourself. And it's highly needed in healthcare to build it ourselves. And this is the way that healthcare costs get solved, in my opinion, is people do this in every specialty, find ways to really apply the technology, and it's getting so much cheaper. So for example, each algorithm that we built, it cost us about $1 million to build each algorithm, and we did many of them. And model creation is being commoditized in a way that I think in the not too distant future, you can just go on AWS, like Amazon. You can go on Amazon and drop in your data as long as you kind of like clean it up and push a button, and you'll be able to run 30 different models on it and pick the model that you like. And so the cost of building these kinds of things are going to decrease significantly in the future. And they're already decreasing, but they'll continue to do so. Okay, so there's different approaches to your data of how you're going to train your algorithm, which is on the right. Those are kind of like the 3 big buckets, which we won't get into. But it is, depending on what you're trying to do, really what you need to understand is things that you can't put in an Excel spreadsheet. You're like, how are we going to do that? There's a way to do that now. And so if you do think that you can automate something inside of your practice or make care better, cheaper, whatever, you probably can. You can probably find a way to do it, leveraging unstructured data. All right, so these are the series of algorithms that we did. I'm going to just jump through this. This is the paper that we did. We automated the report creation so we didn't need transcription anymore. I didn't need to type my notes anymore. And then the software would show us the key areas. So like before I finalized the case, I would confirm it was accurate, and it would circle for me, like, so whether something has a positive margin or not is very relevant. So it'll circle. This is an example of it circling the margin. So I didn't have to look at every margin. I could just look at, on a biopsy, I could just look at and say like, yeah, it's positive there. It's not clinically relevant where it's positive, as long as it's positive, at least in the context of these biopsies. And so it made it so we could speed up, and we actually showed that we had a decreased error rate, a lower error rate, and we were able to do much more work in a day. So these are actual people, not fake ones. And the reason that I have them on here is what is really requires to make a high quality product and to win in the market and make it relevant. It requires, and I say physicians. It should be. I should have written providers, but honestly, I feel like the physicians have to lead in a lot of this. So if you really are going to make a cutting edge product, you're going to get scrutinized. I was scrutinized a lot in the context of this by the community in Utah, as well as by the national community. And frankly, the community in Utah was much more skeptical of me than the community elsewhere. It's just the truth. And so the only reason that you can get away with being novel and still push it through and have it work is if you have the most qualified people involved. And in our healthcare community, physicians are perceived as the most qualified people if you're subspecialized in your area. And so if you are going to do something, you need to do it along your subspecialized expertise, and you have to have physicians involved that are going to go to bat for you, that, yeah, this is safe, we should be doing this, There's no compliance issue. There's no quality issue, because some physicians and some personalities, if you deviate from the workflow, like you're going to go off the flow chart that they all trained in the literature, and you're going to deviate a little bit, you really have to have, you've got to have some big guns in your court saying this is appropriate. So so these are the physicians that actually did the work with me. The ones that started in the initial training of the first one, we'll get to her, not the big picture, but the first 4, we all trained together in the Harvard program doing DermPath. We all did it the same way. And so when people wanted to scrutinize the answers, I didn't want to have a spectrum of answers. And DermPaths, we all practice a little bit differently. I know pathology is kind of used as a black box sometimes, like, hey, pop me out an answer after I put this in. It's actually a lot more sophisticated than that. We try and make it super simple, so like it's a super simple answer back. But we disagree with each other sometimes. And there's one pathologist in the room, like, we're going to sign things out differently. It's just the truth. And same thing, the 4 of us deviate a little bit. And so when I'm training a computer how to do something, I wanted to decrease the amount of human variation possible initially. So I'd want to make sure that it worked as long as we decrease the amount of variability. We all trained under the same person. He's passed away now, but he was world renowned. He was our advisor on the protocol. I pulled him into meetings where he had to explain to health systems, like, this is not only is this appropriate, you should be doing this for the benefit of your patients. And they'll listen to people like that sometimes when they won't listen to me. And that's going to be true for you too. So you do have to have a really good team that will go to bat for you if you're going to do something innovative, because it's really hard to do. The inertia inside of healthcare is astonishing. It is astonishing. Even when what you're doing checks every box for everyone, it just takes some executive who's in power at the top saying, well, let's wait until other people do it. Like, this isn't really fully established, whatever. And it's super hard to break through that inertia in healthcare, because nobody wants to be first. There's always a risk when you do something new. There's a genuine risk. There's also a bigger risk, in my opinion, of doing nothing, especially when health systems in the nation are losing money, which they are, most of them. Most of them are losing money right now. So anyway, I'll get off my high horse on that. But so you had to have a subspecialized team. We then generalized it with another group of dermpaths that trained in a different school of thought than I did, which is, we don't need to get into. But so we generalized it across all dermpath, and I'd say that made it so the AI product was fantastic. Not just fantastic for me and the people that trained in my program, but fantastic for everyone who trained in any program by the time we were done. And then the last one is to April Larson is that first doctor. She's a dermatologist that lives down in St. George, which is where I live. She actually left clinical practice and joined our group, or joined the startup. And that was so important, because our product was built not just for dermatopathologists, but for dermatologists. And you have to have somebody who uses the product to give you feedback, to know what really needs to happen. Like, I know how to make it look great for a dermpath. I don't really know what a dermatologist wants. Like, I think I might know, but the reality is I don't. And so that's what you need, to eat your own dog food. Companies that eat their own dog food, their product is amazing in the end, because they don't want to be inefficient, and they get frustrated. And they'll fix it because they use it themselves. And the companies that don't use their software themselves, and a lot of software vendors are trying to sell you guys products, and guess what? They don't use it themselves. And they just have some engineers create some product and say, hey, this is incredible. You guys should use this. It's AI driven. We can automate these tasks for you. You should use it. Guess what? They don't use it. There's going to be all kinds of inefficiencies and bumps that you're going to hit. And so if you have a software product that has been developed inside of some kind of health environment that mimics yours or is very similar to yours, it's going to be amazing. It really will, if those doctors were part of the development product. So that's why I think physicians and providers have a really unique place in building out the future. And they have a strategic advantage, a genuine strategic advantage. Okay. Let's see. Did I cover my key points here? If you can't tell, I'm pretty passionate about it, and I kind of just go. So I got my timer here running, so I don't go too much. And I do want to talk about I'm not sure if people have questions, you're welcome to just jump up and ask them. We don't need to wait for the end too. So I think the only other key point that I wanted to cover that we haven't yet is to first, execution of a feasible business model wins. So even if your tech is amazing and it does all the things that you need it to do, if you don't have a way to get paid, you die. It's just the truth. You do. And so you have to have a feasible business model. When we started in our space, we took a very different approach and a different business model than other people. The reason that we could do that is because I'm a doctor and I own my own practice. That's the only reason that we could do it. Most tech companies don't have the capacity to do that. You know, they're engineers. There's some business guy who sees the opportunity and they want to maintain ownership of the company, and so they build this thing and try and sell it to doctors. The reality is they don't truly understand how it's going to work, how you're going to get paid, how they're going to justify whatever price point that they're trying to sell it at. So most of them fail. It's not because the technology is not great. It's truly because the business model was going to fail from the beginning, is the reality. And so that's why physicians and healthcare organizations, again, stand in such a unique place, is because you do know what's going to work, what you would buy, what would actually make you more efficient, and if you build for that, that's great. There's problems with having healthcare organizations involved as well, but the point at the end, healthcare organizations hold the key data. That's kind of what I'm going to spend the rest of the time on, I think, until we break. Until I guess you guys can ask questions now, but we'll stop and see if anybody has any questions. So, we talked about like value-based care, proactive care models. Like the future of healthcare is to get paid a lump sum, basically. Like go back to capitation, HMO type thinking. I know they say it's not the same, but it kind of feels the same to me when we talk about it. And I think and that was probably a very un-PC, horrible thing to say, but that's just kind of my just the way that they're approaching it, going away from fee-for-service into other models. I actually think it's a great thing, and it does align incentives in a way that you can build some things to make healthcare better for our community in the long term. So I'm not opposed to doing it. So I'm not making a political statement about it, but I think the reality is there does need to be a change in the financial model in order for healthcare to be viable in my lifetime. By the time I'm 65 or whatever, like things have to change, or the country breaks. It's just the reality. We all know it. We've all been taught our whole careers that that's going to happen. I do see that this is going to solve it, personally. And so the last point there, what's the most actionable data? So healthcare organizations hold the keys of existing, like the full stack of healthcare data. Like patient presents until the outcome is delivered, whether that's death or diagnosis or cured in treatment. The full stack of the healthcare data is held in the healthcare organizations. I mean, if you're a small family doctor in your family practice, like you do have some good data, but you don't have the full stack. You don't have the radiology images, like the raw data. You don't have the raw data of the cardiovascular procedure. Like there's a lot of things that you don't have. And so healthcare organizations really do hold the keys of that, and it's critical. It's absolutely critical in order to build a product that you have the outcome data on your patients, especially if you're going to take care of your patients from a population perspective. The most actionable data is not that data, in my opinion. So if we're going to have a proactive care model or value-based care, that means that we're going to take care of patients to prevent even entering that realm of the healthcare data that they have. So if you're trying to create a system to manage, so let's take diabetes, okay? You're going to get paid a lump sum to manage. Let's say your company's going to manage 100,000 diabetic patients. And that's what your organization's going to do. The government's going to pay you, or the insurance company's going to pay you a lump sum to take care of these 100,000 diabetic patients. Your incentive is to do it at the lowest price point possible, but you also want to deliver the best quality for them as well, which needs to be at least equivalent to what their care would be under this model. In my opinion, it has to be at least equivalent care. It should be better care, but let's just stick with equivalent. Okay, so no loss in quality to do this. So how do you decrease their cost? I'd say that the most actionable data to truly do this is going to be monitoring devices at home. Like leveraging the data that's on their phone, the devices that they already carry around, and leverage. So for example, a lot of diabetics have continuous glucose monitoring. Does anybody get their actual continuous glucose monitoring data, the feed, get their feed, and they've integrated in and they capture it in their health system? Is anybody getting that right now? So one person, two, okay, so a couple. And you're getting the full feed, so you can go back and look on this day, this is the fluctuations. No, so not the full feed, but you're getting some data out of it. Yeah, so, okay, so that's great. So how do you move from what data do I need, and how do we prevent them even needing to come see me? So, and I am not an expert in diabetes. I'm going to pull some things out from med school that are probably super old, so don't judge me too much. So how often does the patient need a hemoglobin A1C? So do you really need the hemoglobin A1C if you have their continuous glucose monitoring feed and you've validated that it's accurate? Do you really need the hemoglobin A1C? No, absolutely not. Is everybody going to order it anyway because that's what the standard of care is? Probably. So we're probably going to order it anyway just because that's what society tells you you're supposed to do. Okay, so what about if you know that their sugars are in control, and you know that the patient is compliant to their meds? So that's another. You know that they're taking their meds appropriately, and you also know that they're keeping up with the lifestyle changes. And you can do that with monitoring. You can automate the whole thing. The technology already exists. Okay, it's just not applied to the scenario. So if you know those things, and you have a chat bot contact the patient, or you have one of these avatars contact the patient and say, hey, how are you feeling? Like, everything going okay? Any problems? Like, and you get back an automated response, integrated response, not just of what they say, but there's also algorithms that can determine like how stressed the person is, whether they're under stress, or how they actually feel emotionally. You get all this data back, and it says they're being compliant, they're doing everything that they're supposed to do, they're taking their meds, they're following through with the regimens, and they don't have any issues. Do they need to come in for the visit? They don't need to come. In my opinion, they do not need to come to the visit. Okay? So what happens right now? Automatically, they've got to come sit in some room for 3 hours and wait for their doctor to see them, to talk about things that they don't even need to talk about, or to do so. Or let's say that there is a problem. Let's say, hey, there is an issue, and so what's the most cost-efficient way to address that issue? And I don't get into it, as I'm not an expert in the area, but I'm just using it as an example of what can be in a healthcare organization. And so if we're really going to be proactive and take care of patients that ensure like the highest quality for them, they want their diseases identified and treated early. Like, that is better for them if it's done super early. And the most actionable data to diagnose things early or to pick up issues early is at-home wearable devices or Internet of Things devices, surveillance type things at home. And I don't want to get into like the security issues, and there's other issues. There's all kinds of things that that go along with that. But using the technology in your space, no one is going to see the answer better than you. I'm not going to see the answer because it's not my area of expertise. So right now, me talking about diabetes is like I'm one of like the tech bros saying, hey, this is going to be amazing, but I have no idea what I'm talking about. Like, that's kind of like me and diabetes right now. But I'm just using an example because I know most of you guys take care of that patient cohort, and it's a large patient population. Okay, so so these are just some examples that I came up with. And of where I see, I consider this low-hanging fruit. Like, I feel like the technology's there. It just requires the health system to think through it and invest some resources and really believe that it's possible. So preventing, we already talked about in the context of diabetes, some of this, how to prevent inpatient visits, readmissions, preventing ER, there's, if you just pick your specialty, orthopedic surgery. How do you prevent how do you prevent a readmission in somebody who is after an orthopedic surgery procedure? Like, can we do a better job monitoring the patients, intervening before they actually need to come see the doctor, identifying 24 hours before someone's going to show up at the ER? Can we identify the person? Absolutely. Absolutely we can if we set up the structure. And I don't see anybody really have a robust structure for some of these things. I hear a lot of people talking about it, that this is the future, but I don't see any organizations really implementing it. And in order to implement some of this stuff, like I said, you do have to have the entire stack of the health record. And the stewards of those are large healthcare organizations for the most part, and most healthcare organizations are afraid to innovate. They know that they do a bad job at it. A lot of them don't even have the resources given the current economic environment, but they hold the keys. They hold the keys to the data. The tech industry is a lot easier to get data, just because of, it's a different type of organization and different standards. So pairing those two together, if your healthcare organization can pair those two together, and even if you don't have the resources to it, you can raise resources through a startup to put those two pieces together for you. If you think that's possible, text me and I'll help you, because our society needs it. And I have personally talked to about 5 different healthcare organizations that are large, that I have personal friends inside of it. They all say, hey, yeah, that's amazing, let's do this. And guess what happens? Nothing. Nothing happens. And I think we all know that. I mean, you go talk to your administrator at your hospital, and you've got the best idea in the world. It's really hard to get approval across 15 different things for something that's like, hey, if we have a scribe, we can be more efficient. Like, that's hard enough to get, right? Imagine trying to get a health system to bite this off. I mean, they just don't. And so it in my opinion, the way healthcare is going to go in my lifetime is whoever solves this equation wins. Whoever solves it is going to win in a huge way. That's why Amazon is buying healthcare systems. And they have. So if you look into the tech industry that's involved in this, they're buying like primary care organizations, and this is the reason why. And I don't really know that that's why, but this is what I would be doing if I were them and had the resources. And so in my estimation, if you can solve this problem, if you can truly take care in a proactive manner of a large patient population at a low price point, then, and healthcare reimbursement always stays the same, whether you do a great job or not, pretty much stays the same, and they're trying to change that, obviously. But if you can solve this and make your organization profitable, even by like 5%, if you're in a large organization that was 5% more profitable, you would be out of this world profitable in regards to healthcare organizations in the country right now, and you would be able to wrap up the whole United States underneath your umbrella. Either you could buy them, or you could leverage your technology into them, and they'd be reliant on you. And so I see massive healthcare consolidation happening under this umbrella. How that involves your particular practice, I think that, like Adam had said, that if you're not on board and you're not using the technology as it comes available, and actually I think the healthcare organizations have more to worry about, the larger ones, that if they don't come up for a solution with this, they're going to just get eaten by somebody that does. And I think that is all. That's my message. I hope it's not depressing. I hope it's a good message. And I think that's it. So, thank you.
We got time for a question?
Adam's in charge. Yeah, he says yes.
I appreciate your commentary on the inertia of large healthcare organizations. I've certainly experienced that myself. In terms of your proposed solutions here, and the organization that solves this problem first is the one that's going to win. It seems to me that part of the problem, part of the Rubik's Cube, the puzzle that you've laid out, involves not just the healthcare organizations or the technology, but the patients themselves. And some of your proposals that involved wearables and Internet of Things devices and remote patient monitoring, I'm not sure amongst my patients how many of them are going to be interested in having a lot more wearables and technology and the Internet monitoring their activities at home. But I wonder what your experience is with that, or if we have any sort of data about that, about what patients at large, what their willingness is to invite, maybe not Big Brother, but the medical industrial complex into their lives and their personal homes.
Yeah, for sure. No, that's a great comment. There's ways to do it, and obviously, the patient's steward of their data. The truth be told, most patients have an email account that they're not paying for. Right. So if you have if their email ends at gmail.com, at yahoo.com, they already have probably estimated, depending on how old they are, somewhere between 15 million and 30 million data points on them that big data has on that person. And so and in terms of like bringing new devices in their home, you don't really need new devices in their home. You just need them to be willing to allow for you as their healthcare provider to access the data that's already there. So I don't even think they need new monitoring. My experience has also been that remote patient monitoring is already live, and patients haven't. I'm sure there's patients that have a problem with it, but a lot of patients will buy into remote patient monitoring when they know it's at their benefit. And so, yeah, I'm sure there'll be patients that don't like it, that are upset by it or whatever. And I don't really like the concept of Big Brother, honestly, just who I am inside, but I think I don't see a way around it, and it's already happening all over. And so part of it is just bringing awareness to your patient, like, hey, the data's already there. All you got to do is plug it in, and guess what? Your insurance company will pay you if you do it. And I think insurance companies are a part of it. They're the ones that are driving this new model of healthcare, and so I think that once you can prove that there is a true health benefit to the patient, and it's measurable, most insurance companies, as long as it's compliant, will come up with some way to leverage it because they're trying to improve the health of the patient too and decrease their costs, which it should do. So yeah, the reality is we don't really know until somebody tell you do it. You don't really know until you do it. Using the blockchain, there's a lot I could go into about how the blockchain plays into it, which we won't do right now. But anyway, hopefully that at least talks about it. Sorry.
Let's take the 2 questions at the microphones.
Greg, thanks for making the drive up. It's good to see you.
Oh, thanks. Likewise.
If you think this, Pathology Watch can 5x what a pathologist can do in a day, I assume that also comes with a decrease in need for pathologists by half. What would this all do to medical training and the future of all physicians, right? It really changes the workforce.
Yeah, so I don't know the pathologists are worried about it. If any pathologist goes onto a job board, there's probably about 2,000 open jobs right now in pathology. There's a huge demand in pathology, and the training programs aren't keeping up with the population growth. And so I don't, and that said, also, at least in my specialty, I looked into this a lot. There is not a single pathologist, or not a single dermatopathologist in most countries in the world. And when you can bring the price points down in a semi-automated to an automated fashion, it opens up access in an amazing way. And so in terms of who's generating the samples, so like in a lot of the countries that I did look at, so we did. Well, anyway, I only want to talk about things that are publicly available. So. We looked at it. So we did look at it. I'm not worried about a demand problem in DermPath. That's the area that I looked at, and I really went deep. I actually think the demand will increase significantly as the price points come down, and when the tech is truly implemented fully, the price points. To crunch an algorithm and generate a report, if you don't need the doctor, the true cost is less than $1. Whereas right now, Medicare reimburses just for the professional component in Utah something like around $30. And so and you got to make money too. So I'm not saying that that's how much it would end up costing. There's other costs involved, but anyway, yeah. So and how that applies to other physicians, I can't remember if I heard it yesterday or at a different conference where people say, well, I don't think the AI is, was this yesterday? AI is not going to take your job. It's going to be a doctor that uses AI that takes your job. Yeah, and I think that really is true. I also think there's a huge demand problem for physicians that's projected into infinity. And I don't know if you've heard people talk about it. Like, so one of the health systems I cover is Intermountain down in southern Utah, and their chief strategy officer came down this year and he painted the picture. He said, if Intermountain hires every new medical school graduate for the next 30 years, something like projected out, I think it was maybe 10 years, I can't remember, that would only cover attrition. That would cover attrition only and not growth in terms of like the Intermountain primary care and physician network. And so I really don't think that anybody needs to worry about their job. Like if you went through the price to pay as a physician, you're not losing your job. You're not losing your job. You might have to reapply your skill set and learn a few other things and, adapt as the world changes. But I really don't think that there's going to be a demand problem for physicians personally.
Thanks.
Yeah.
Thank you for a fascinating presentation. Can you teach AI to make a reliable diagnosis of melanoma histologically?
So melanoma is fraught with difficulty. There actually was an AI company that looked at that specifically out of Israel, and the company failed because they didn't have a business plan that was viable, but the technology was great. And the issue with melanoma is if you took 10 dermatopathologists, some melanoma is obvious, and absolutely an algorithm can diagnose it, and we did it. So we were able to diagnose melanoma. The issue really comes down to
Dysplasia.
Yeah, so severely atypical lesions, and one dermatopathologist will say, yeah, it's actually melanoma. Another dermatopathologist will say, no, it's not. It's a severely atypical, George Murphy calls them meltumps, melanocytic lesion, melanocytic tumor of unknown malignant potential. And so there are these big gray areas, and the true issue is the algorithm can never be better than your data set. You can't, an algorithm is not God. It is only as good as your data set. And so if your data set, if our professional society had it totally cleaned up and saying all these are melanomas, all these are severely dysplastic lesions, and it was very clearly delineated, an algorithm can follow those parameters better than a human, as long as the parameters are clean. And the issue with melanoma is the parameters aren't clean. And so we didn't step into that. We stopped at severely atypical lesion and just kicked it to the human. We're like, we're not even going to get involved, just because, for that very reason. And there's obviously like litigation and malpractice and things like that associated that, we weren't ready to buy